risk in case they do need radiation, of now you're radiating a breast that has an implant in it. Versus the women who have mastectomy, mentally they don't do well right away because they woke up and they don't have any breast tissue anymore. In a delayed fashion, they go back for reconstruction. They tend to do much better cosmetically because they had all their radiation, all their treatment, and now they're, one of my patients called it the year of the boobs. You know, I had the year without the boobs, these are the year of the boobs. Okay, that's how she thought about it.
Does insurance cover the
reconstruction?
Yeah,
mm-hmm.
Since it's part of the cancer.
Mm-hmm. Yep. When we talk about estrogen and progesterone and HER2, various hormones that we check, they send off for at least about 5 things right away on everybody's tumor. You can have them send out to California for another about 20 additional genetic markers. But right away they check for estrogen and progesterone. Those are kind of the first 2 big hitters. And believe it or not, it is good to be both estrogen and progesterone positive. We'll talk in a minute about HER2, which is another hormone that we look for. And so if you're triple positive, that's actually fantastic. Because that means that if I suck all your hormones out of your system, the likelihood of your cancer coming back is less likely. Okay? So you're better. If you are triple negative, ER/PR negative, HER2 negative, that's bad. It's a bad prognostic indicator. The cancer was never estrogen driven to begin with, so it was always probably bad. So you get a 40-year-old female who's diagnosed with breast cancer and she's triple negative, that's not going to be a good setup. Okay? So you look at all these receptors because you want to see what you can do for them pharmacologically to decrease their risk for breast cancer long term. Same goes with HER2. Okay, so this is a receptor on the breast cells. Basically, it helps control healthy breast cells grow, divide, and repair, and basically it goes haywire with regards to cancer. Okay, so we're going to an overexpression is going to be called HER2 positive. So if it's overly expressed, we can actually suppress that, which would decrease the risk of breast cancer in the future. So we have lots of hormonal therapies that we can do. You'll hear women being on tamoxifen, Femara, Arimidex. There's actually clinical trials that are ongoing for women who do not have breast cancer, who are at increased risk of developing breast cancer in their lifetime, of being preemptively placed on Arimidex for 8 years. 8 years. Did I say that right? 8 years. I thought I slurred through it. To see if they can decrease their risk of breast cancer long term. Okay, so they're looking at that as pre-treatment, so to speak. Okay, but basically most women will get placed on these drugs. Vast majority of them don't have any adverse events. They think it's like a sugar pill. The whole goal is to suck estrogen and progesterone and potentially HER2 out of your system, decrease your risk of recurrence long term. Okay. So you got lots of them. Tamoxifen. They work in various ways. If you only have HER2 receptor being positive, you give them Herceptin. Hysterectomy and oophorectomy, so you would want to offer this or at least dialogue about this with your patient who has breast cancer, who is young, who has increased risk of ovarian cancer, because we know that ovarian cancer is certainly much harder to find diagnostically than breast cancer. It's not like you'd have to be a really good clinician to feel every single patient's ovaries. You don't have to be a really good clinician to feel every single breast tumor. Okay, so you just want to make sure that. But you also want to have a serious discussion about how it might impact their quality of life, because certainly it will throw them into early menopause. Yeah, I'm trying to come up with more words. We talk about BRCA1 and BRCA2 testing. So this is that genetic component for breast cancer. BRCA1, BRCA2 increases our risk for breast cancer, ovarian cancer, prostate cancer. You boys can get BRCA1, BRCA2 too. I said that twice. Okay, you can get it also, I should say. So certainly we know that those women who are BRCA1, BRCA2 positive have increased risk for genetically related breast cancers. So basically the most recent stats, so basically normal breast cancer risk, 12% in your lifetime. BRCA1 positive, 55 to 65% of the women who inherit that gene are going to develop breast cancer, substantially higher. Okay, 45% of women who inherit the BRCA2 gene. When we talk about ovarian cancer, only 1.4% of the population, but remembering ovarian cancer is the 5th leading cause of death. Like, it's not that common, but it kills you. okay? 39% of people who develop have BRCA1. So if you have somebody who's BRCA1 positive, she's got a 55 to 65% chance of developing breast cancer and a 39% chance of developing ovarian cancer. That's a bad day, okay? BRCA2, 11 to 17% chance that she'll develop ovarian cancer. So the risks are extremely high, okay? Breast cancer in men, it happens, and it's always bad because it's always found late, okay? Because men, your male patients have this misconception that that's a girl disease. That only happens to females, okay? No, okay? It happens to boys too. So you still want to look at the chest wall. You maybe don't do necessarily, I honestly say, do I actually do a clinical breast exam on men? No, I don't. But that's maybe why you're now palpating the chest wall, okay? And certainly I think we've all known and seen men that have pendulous breast tissue, and you've got to check them, okay? You got to have them sit up and move around. Maybe you don't tell them, I'm doing a breast exam on you. I would not approach it in that manner, okay? But certainly palpate the chest wall. Certainly as you're listening to their lungs from the anterior aspect, take that opportunity to look at their tissue as well, okay? Maybe have them lean forward. Hey, raise your arms up for me. I'm checking your shoulders, okay? Look to make sure that you don't have any retraction of any tissue. Just lie to them, okay? Typically over the age of 50, basically they have a poorer prognosis than women long-term because they're typically found later. It's not that what they get diagnosed with is necessarily any different. It's not like they have their own subset of cancer, okay? It's just that they're not found so much later. So basically, when we talk about if they're node positive, their 5-year survival rate is only 69%. Node positive. Yeah, if they're node negative, still 88%, 5 years. That's not great. I mean, for women, we talk about a cure if they're node negative. We don't really talk about that with guys, okay? So be very cognizant of that within your male population. All right, let's take, what time is it? 3:28. Let me go grab Dr. Pash, we'll take a quick break, we'll come back at 3:45, and we'll do OBGYN Jeopardy. I will promise that it will be beneficial for you to stay for OBGYN Jeopardy. Okay.